Good afternoon. Now with the audiovestibular medicine. With you Soha Mekki, Professor Audiovestibular Medicine, Zagzag University. Audiovestibular medicine specialty includes all basic and advanced aspects of sciences related to auditory perception and balance. Clinically concerns all prophylactic screening, assessment, treatment, and rehabilitation of hearing, auditory perception, communication, and balance disorders from birth onwards. The first lecture is about auditory assessment. The auditory system includes outer, middle, inner ear, its nerve, and the central auditory nervous system. Hearing starts by exposure to a mechanical energy, which is the sound transmitted through the external canal and vibrating the tympanic membrane and middle ear ossicles, and then transduced into electric energy in the inner ear, picked by the eighth nerve to be transmitted through the auditory pathway to the central nervous system, to the central auditory nervous system. So there is a series of conduction through the external and middle ear, and then transduction in the inner ear and the neural through the auditory nerve, brainstem, subcortical, and cortical auditory structures. Audiogram chart includes a vertical axis that includes different frequencies or different tonal frequencies from low pitch to high pitch as we heard, and also a vertical axis representing different amplitudes from the very soft or low amplitude to a very loud or the high amplitude. This is an example of low frequency, low amplitude sound. And this is an example of high frequency, high amplitude sound. So we can see that through normal hearing we can hear all the sounds and enjoy all the aspects of music, and also we can communicate through the spoken language through hearing different phonemes that we are using in speech production. This is a very important item, that we can hear all the frequencies included in all the spoken phonemes, so as we can hear clear speech. This is called the speech banana. Basic audiological evaluation includes, for adults, the history, otoscopic examination, tuning fork test, pure tone audiometry, air and bone conduction, and speech odd testing, tympanometry, and acoustic reflex. Of course, this is different for the children. First, the tuning fork test, which is a roughly or a rough estimation that can detect if there is a hearing loss and distinguish between conductive and sensory neural hearing loss. The most famous and important test from tuning fork test is the Rene and Weber. The Rene used for comparison between bone and air conduction. For bone conduction, we use the base of the tuning fork placed on the mastoid area And then for air conduction, if the sound is not heard again through the bone conduction, we are using the vibrating top near the external ear for assessment of the air conduction. If the air conduction is better than the bone conduction, then the Rene is called positive, and it is representing the healthy or the sensorineural hearing loss. And if the bone conduction is better than the air conduction, this represents a conductive disease. The Weber test, the tuning fork is placed on the patient forehead or in the middle line. If the sound lateralizes, which means that the sound is louder on one side than the other, then the patient may have either an ipsilateral conductive hearing loss or a contralateral sensorineural hearing loss. There are other tests using the tuning fork, like Ping and Schwabach also. For the quantitative accurate assessment of hearing, we shift for audiometry, which including the audiometer that produce a pure tone at different frequencies and intensities, and through a transducer using the air conduction pathway like headphone, insert phone or loudspeaker, and another transducer which is a vibrating transducer stimulating directly the inner ear, so that will represent the bone conducted sound. And through comparison between the threshold of the air conduction and bone conduction, we can estimate the type of hearing loss. All of this should be done in a sound booth, which is a sound treated room, preventing the ambient noise from interference with the test. So as we can assess the hearing threshold and the type of hearing loss at different frequencies and different intensities, so as we can detect the handicap of this patient and go on for treatment. And also to assess his ability for a normal speech through assessment if he can hear in this frequency range and intensity range which is needed for normal hearing of the speech items. The procedure including first doing assessment of threshold at each frequency, and the threshold is the minimum amount of sound that could be detected 50% whenever exposed to the patient at specific frequency, first through air conduction and then through bone conduction, and then doing the audiogram interpretation to detect the degree, type, and configuration of hearing loss in order to go on with treatment or rehabilitation. The degree of hearing loss will depend on the amplitude at each frequency that the threshold is. Normal, it depends on the amount of or the threshold of air conduction. Normal for adult from 0 to 25, for children from 0 to 15 dB, mild for adult from more than 25 to 40, and for children more than 15 to 40, and then for both adult and children the moderate is more than 40 to 50, moderately severe from 55 to 65 dB, and the severe from 70 to 90, and the profound hearing loss more than 90 dB. But for detecting the type of hearing loss, if it is conductive, sensory neural, or mixed, we have to compare between the threshold of the air conduction and bone conduction. This is a pure tone audiogram for normal hearing subjects, detecting the threshold at each frequency. It is at all frequencies below the normal range. For conductive hearing loss, the bone conduction is within the normal range, but the air conduction is below the normal range. This represents a conductive disease. The sensory neural hearing loss, both the air conduction and the bone conduction is affected and are overlapping. They are the same. This is an example of a severe in degree and sensory neural in type of hearing loss. This is a severe sensory neural hearing loss. For mixed hearing loss, both the bone conduction and the air conduction are affected, but they are not the same. They are not overlapping. The bone conduction is better than the air conduction, but they are both below the normal level. This is a mixed pathology between conductive and sensory neural, which is called a mixed hearing loss. Also, the flat the audiogram configuration. First, this is a flat audiogram, which means that all frequencies are affected at the same levels. The audiogram configuration is important to detect some disease, an indication of some disease. This is a sloping, which is different from the low to high, sloping more severe for the high frequencies. This is the reverse sloping, more severe in the low frequencies. And this is a tent, the affection in the low and the high, but not in the middle range. And the reverse, the cookie bite, the affection is more in the middle range frequency. All of this is important to detect the degree of handicap and to start in intervention. Sometimes we use the pure tone average of the air conduction threshold to detect the percentage of hearing impairment. Now we are going to another stimulus, not a pure tone, but a speech stimulus. This is called a speech audiometry. We can do speech threshold test to detect the speech detection threshold, or to detect the speech reception threshold, which is the lowest level at which the listener can identify speech stimulus 50% of the time. And this should be matched with the pure tone average. Also, we can give a favorable intensity or loudness level, and then test the patient ability to discriminate speech and detect a correct percentage from excellent to very poor. Of course, whenever the pathology is peripheral conductive, there will be an excellent or a very good speech discrimination. And whenever the pathology is going centrally, it starts to be poor. And in the sensory neural, as there is some distortion in speech production, in speech perception, so the discrimination will range from good to fair to poor according to the degree. Now, after we did the audiometry, we will go to another test of middle ear analyzing system, which is called impedancemetry. It is a way of assessing the manner in which the energy flows through the outer and the middle ear into the cochlea, if it is transmitted and how much reflected. Impedance audiometry includes tympanometry and acoustic reflex measurement. This test is done for detection of middle ear pathology, differentiating cochlear from retrocochlear pathology, estimate sensitivity. This is the instrumentation. And the concept in tympanometry is to measure how acoustic impedance of the middle ear system changes as air pressure is varied in the external ear canal. Whenever the pressure in the external ear is equal to the pressure in the middle ear, there will be a maximum compliance. But whenever there is a change, whatever this positive or negative, there will be a more reflection of sound and a minimum compliance or transmission of the sound. So the tympanometry measures includes middle ear pressure, measuring the middle ear pressure and the middle ear compliance. The middle ear pressure could be as the atmospheric, could be negative, could be positive. All of this, the negative and positive are pathologic, but atmospheric is normal. Middle ear compliance also the normal compliance of the middle ear, but could be fixation, hyper compliance, or no compliance, and this is a pathological measure. This is a normal tympanogram in shape, pressure, and compliance, which is called type A audiogram. And this is a type AD, or a deep normal peak pressure but with increased compliance. This is pathological. There may be, for example, ossicular discontinuity or a hypermobile tympanic membrane. And this is on the reverse a type AS, or a shallow normal peak pressure but reduced compliance, which reflect a stiffness in the middle ear or in the tympanic membrane. And this is a type B, or a flat audiogram, a tympanic membrane which is not moving due to high middle ear impedance. This reflects a pathology behind the tympanic membrane, like otitis media. And this tympanogram type C, when the peak pressure is lower than minus 100 dBA, which indicates negative middle ear pressure, which is usually with the Eustachian tube dysfunction. The stapedia reflex allowed acoustic stimulus will cause bilateral contraction of the stapedius muscle, and we measure reflex response on ipsilateral and on the contralateral ear. The acoustic reflex measurements include three primary acoustic reflex characteristics: presence or absence of the reflex, reflex threshold, and reflex decay. So, from basic to advanced audiometric testing, after we finish this basic audiometric testing and tympanometry and acoustic reflex, we have extended high frequency audiometry, we have central speech testing, we have advanced impedancemetry, metry, autoacoustic emission, evoked response audiometry, EKG, ABR, etc. And also we have alternative speech choices for speech audiometry, not only using the spondees or the phonetically balanced, but other advanced spoken stimuli. And also this is an example of advanced impedancemetry equipment and traces. This is the autoacoustic emission. This is the EKG. This is the auditory evoked potential, which is usually used for the newborn and for the children, and in some medical legal conditions and in some neurootologic conditions. And this is a trace of the ABR. We can use the ABR for measurement of threshold and also for the detection of the site of lesion. Whenever we use all the basic and the advanced audiometry, as we said, we can detect the degree of hearing loss, the type of hearing loss, the speech perception abilities of this patient, and so we can detect the management or the proper intervention. Either medical treatment, surgical treatment, or rehabilitation. Rehabilitation includes the remediation therapy, which we can use central auditory processing remediations, and sometimes we have to use these central auditory remediations in some central auditory processing disorders. And if we couldn't find a medical or surgical way of treatment, we can go for a hearing devices, which includes the hearing aids, which could be air conduction or bone conduction hearing aid, implantable or not implantable hearing aid or hearing devices. This is an example of the air conduction hearing aids. From very small complete in the canal hearing aid to behind the ear hearing aid, and the implantable and the most famous is the cochlear implant, which has an internal part inserted inside through an operation, and then putting an external part that transmits the sound directly to the auditory nerve, bypassing the severe to profound sensory neural hearing loss that couldn't be rehabilitated through the traditional hearing aid. Thank you for your listening, and I know that it is very tough, and we will explain or going on through the small sessions group to how can we applicate, or how can we use these informations in clinical applications to study or to assess the hearing of the hearing impaired subjects, and how can we doing the proper intervention for them. Many thanks and good luck.